Good morning. Today we are having a important case discussion. Diabetic foot infection is now a part of long case discussion in MS and DNB examination. The case will be presented by Dr. Behrul Huda. He is a second year DNB resident at Southeastern Railway Central Hospital. And today Professor Shogoto Samanto is Professor of Surgery at Arambagh Medical College. Will moderate, and I'll also be there to assist him. Dr. Behrul, you can share your screen and start presenting.
Good morning, sir. Good morning to all of you. Myself, Dr. Behrul Huda, DNB resident from Department of General Surgery, Southeastern Central Railway Hospital, and I'm here to present a case of diabetic foot infection and its management. So, a 64-year-old Mr. Narayan Das, by occupation is a driver, resident from Kharagpur, presented with complaint of pain and swelling over the outer aspect of left foot for 1 month and ulceration over the left little toe since last 15 days. History of present illness. Patient was apparently well 1 month ago, then complained of pain and swelling over the outer aspect of left foot towards the little toe following a trivial trauma while walking 1 month back. Initially, pain was throbbing and localized to the same region. Continues, which aggravates on movement and relieved by medication. It was associated with swelling and later mild fever and small quantity of purulent discharge from the left lower aspect of foot. Following treatment after consultation with local practitioner, there was symptomatic improvement in form of reduction of pain, swelling, discharge. Later, there was again a history of trauma to the tip of left toe, leading to small abrasion injury over the left toe, which gradually progressed to involve the entire toe with reappearance of foot pain since last 15 days. Past history: patient is a known case of type 2 diabetes mellitus not on regular medication for the past 5 years. Is a known case of hypertension, not on regular medication. Is no history of furuncles or abscess at the other body part was noticed. No history of chronic kidney disease, coronary artery disease, tuberculosis, Hansen disease, hypo or hypothyroidism, rheumatological disorders, varicose veins, and paralysis. And there's no previous history of hospitalization or surgery in the past. Family history: there is no family members are affected from diabetes mellitus or hematological disorders, cardiac or vasculitis related illness. Personal and social history: a patient often smokes in the form of tobacco, 5 packs per year, and he is occasionally he does alcohol consumption for last 12 years occasionally, and is married and living with wife and 2 children. Physical examination and general survey. I have examined the patient with...
Wait, Behrul.
Yes, sir. Yes, sir.
Wait, we go back to the history of present illness. We
Yes,
have
sir.
some, because your history is not complete yet. We have some discussions on the history.
Yes, sir.
Right.
So you have,
yes, sir. You start first, then I will join in. No problem.
Okay. So you have given the history of swelling and ulceration.
Yes, sir.
And in a patient of diabetes,
yes,
this
sir.
ulceration and swelling may be for a number of reasons, and a diabetic patient may have a lot of other diseases in the body. So what you have described is just the pain and the ulceration, but you need to describe
yes, sir.
other symptoms, like you have just only fever.
Yes, sir.
Okay.
Yes, mild fever. Yes, sir.
Diabetes may have eye problems, may have kidney problems, may have cardiac problems. Okay.
Yes.
So
yes, sir.
in history of present illness,
yes, sir.
Which by convention goes by the saying of negative history, is not exactly negative history. You have to ask all other systemic symptoms, because only one presentation of foot ulcer and swelling is not enough to exclude other systemic complication of diabetes mellitus. You got my point? You have finished up only describing the history of present illness with pain, swelling, and the ulcer. We want that you describe other systemic symptoms in history of illness, whether he has, how is his appetite, any history of weight loss, any other systemic symptom apart from fever. Okay. His urinary symptoms. He's 64-year-old gentleman. He may have associated obstructive uropathy. He may have chest pain. He may have cough. He may have exertional dyspnea. He may
Yes, sir.
have cerebrovascular disease in the form of any history of fainting attacks. Okay, any unconsciousness, any neurodeficit. So all things should come in history present list so that you can understand that this is a patient of diabetes mellitus who has got only foot infection and nothing else. His other systems are not being affected because diabetes can affect all the systems in the body.
Yes, sir.
As more
What is one-
relevant as Dr. Huda, the
Yes, sir.
problem of diabetes, as Professor Saha pointed out, is a general affection of the entire body. So all systems are more or less involved. But to your mind, what besides taking a history or general regarding, say, for example, the huge organs that are usually involved in diabetes mellitus, regarding foot infection, what you were talking about, what histories do you think are of paramount importance, which is missing in your story?
Sir, there may be history of reduce in the sensation of lower limbs.
Exactly. So if we are talking about what we call a diabetic foot, it comprises of certain associations, isn't it? Diabetic foot is a complex problem in which we have got associations. These are present. So one, as you have talked about, is neuropathy, isn't
Yes,
it?
sir. Yes,
So
sir.
you need to ask about neuropathy. Now, regarding neuropathy, there are a few things that you need to ask. I will point out. You have to ask the patient about his footwear, whether he walks barefoot, whether he has changed his footwear recently, whether there was any foreign body implantation in his foot. So these
Yes, sir.
questions also need to come in your history. Okay,
Yes,
regarding his foot,
yes, sir.
neuropathy. The other one obviously is vasculopathy. So obviously you need to ask about whether the patient had history of intermittent claudication and things like that. Okay,
Yes,
so
sir.
vascular history, neurological history are extremely relevant and important in cases of a diabetic foot. You must take those histories. Okay,
Yes, sir. Yes,
right.
yes,
So your history is missing those things.
yes, sir.
Now, okay, shall we proceed on to the examination then?
But
Yes,
if
sir.
the patient has vascular disease, patient may have intermittent claudication. So the site of claudication is important. Okay, so history should be comprehensive. Try to understand that history is not confined only to the swelling and the ulceration. It will be a comprehensive history taking the whole systems into account. Okay, so
Okay, sir.
pass on to examination.
So, I have examined the patient with after informed consent in a well-lit room after adequate exposure. Patient at the time of examination was alert, conscious, cooperative, and oriented to time, place, and person. Patient is lying comfortably with both limbs stretched on the examination couch. Patient is of average build. Height is 165 centimeter. ECOG score of 1. Weight of 66 kg. BMI is 24.24 kg per meter square. And he has got limping gait. Hydration was adequate. There is no signs of pallor, cyanosis, clubbing, jaundice. Edema was, but the edema was present in left lower leg. There is no lymph nodes palpable. Pulse rate is 98. BP is 140 by 86 millimeter of mercury. Respiratory rate was 16. Temperature was normal, and there was no any obvious deformity, and there's no pigmentation in body. Local examination. On examination of lower limbs. Both I have examined both the right and lower limbs. Right attitude was neutral. No, there is no deformity. Skin in skin, hair, and nails. Dry and scaly skin was present. Sparse hair with no onychodystrophy. On left, there was a 10 degree of dorsiflexion at angle. There was no deformity. There is an ulcer present, dry and scaly skin with hyperpigmentation over the dorsal aspect around the ulcer. Sparse hair with onychodystrophy. So a single ulcer located over the left foot dorsum extending to the palmar aspect of occupying the distal outer aspect. Margin was irregular with sloping edge all around with red, blue, and white zones. Floor is formed by the healthy granulation tissue with minimal slough interspersed and with exposed fourth of the fourth tendon of the fourth toe was exposed with minimal serous discharge present. There's no gangrenous changes over the limb, no dilated veins, ankle joints grossly normal, and area of pressure points were normal. On palpation, temperature was normal over the ulcer and surrounding area, and ulcer and the surrounding area was mildly tender, and the ulcer was about size of 8.5 into 7 centimeter, and other inspective findings are confirmed in on palpation. Base of the ulcer was formed by muscle over dorsum and plantar mildly indurated. Granulation, which bleeds on granulation, web spaces was normal, and long bones were normal. There was normal capillary and normal capillary refilling time. There is no palpable inguinal lymph nodes. There is no peripheral nerve thickening, and all the peripheral pulses were palpable. So all the dorsal petrous artery, anterior tibial artery, all the peripheral pulses were palpable, and there was slight dimness in the neurological sensation. There was slight distended sensation by using monofilament, and ankle reflexes were normal. There was no decrease in muscle bulk of the legs, both thigh and lower leg. On systemic examination, respiratory system, bilateral vascular breath sounds heard. There's no added sounds. Abdomen and perineum, they are soft, non-tender, no visceromegaly. Normal bowel sounds heard. Perineal examination was normal. On cardiovascular system examination, S1, S2 heard. No abnormal sounds heard, and central nervous system and spine was normal. So provisional diagnosis. It is a case of diabetic foot ulcer of left side of the lower leg, Wegener's grade 1B.
Right. Dr. Huda, can we go back to the first few slides of your examination? We will start from there.
Yes, sir.
You see, yeah, this is where you have started. Fine.
Yes.
This part is absolutely fine. This slide. Okay.
Yes.
Next.
Yes.
Next one, please. Next slide.
Yes, sir. Yes, sir.
Yeah, this is also good. So I would say, yeah. So what you have done is you have calculated the BMI, which is fantastic. You must calculate the BMI.
Yes,
now,
sir.
Your gait, hydration, the cyanosis, these things are okay. This lymph node is not palpable. You mean this is cervical lymph node, isn't it? So
Yes, sir. Yes, sir.
Yes. So this has to be mentioned. Now,
yes,
if you have got edema present only in one limb, it is also important to also note how far the edema is present up the limb. You see,
up to the
because,
yes, sir. Yes, sir.
Yes, because you see, this is a patient in whom you have got this edema is you are trying to explain. At the end of the day, when I will ask you how do you explain this edema, you are obviously going to put the blame on the ulcer and the infection. So one of the ways to assess how much the involvement is there in the leg, we will have to look at the upper level of the edema. You see, the edema extends up to this area. So this is very important. So you have to mention that. Next.
Yes.
Actually, edema you are mentioning here na, is our description of generalized edema. It's not it's a edema that more specially should go to the local examination. There is an ulcer, and around the ulcer there is a swelling, which is edematous area. So in this edema, you can say absent, because here you are mentioning generalized edema, not a localized edema which comes under local examination.
If you are mentioning edema here, but basically means you have got a flaring infection where the muscles are edematous. You know, there is either there is edema in the level of the muscles or under subcutaneous area. So this signifies something quite different, you know, if it is present in the leg as well. Okay. Next.
Yes, sir.
Next slide. No obvious deformity. Arch. So if you look at let us have a little discussion at this point before we go further into the examination proper. So diabetic foot, what are the areas that need to be examined during your examination? Any ideas? You have done quite a bit, but
yes,
what needs to be examined? So essentially, you will need to have an examination of the ulcer, isn't it?
Yes, sir.
Next, you will have to look at the foot and look for foot deformities.
Yes, sir.
Deformities
This
of the foot.
deformity, what all you have looked for? Patient may have loss of arch. Have you looked for is the normal arch is maintained or not?
Yes, sir.
My point, patient with diabetic neuropathy may have loss of foot arch.
Yes, sir.
Foot may become flat.
Yes, sir.
Pressure points might change.
Yes, sir.
So
There may be deformity in the toes.
Exactly. So there are lots of deformities which are possible. We will obviously discuss all that. Third thing that you have to examine for neuropathy, which you have done to some extent. And number 4, you have to examine for vasculopathy, ischemia. So these are the 4 areas which have to be covered in an examination of diabetic foot. Now let us look at the presentation that you have made. And also you'll have to look at the other lateral diagnosis possible. A diabetic patient does not necessarily need to have a diabetic foot. That is the most likely diagnosis, but he may have other diseases as well. So you have to keep in mind those things as well. Okay,
Yes, sir.
next slide, please. Next slide, please. Right. So here you have written dorsiflexion at the ankle. Why does he have 10 degree of dorsiflexion at the ankle?
Sir, he was avoiding to put pressure on the ulcer area as it was in the plantar aspect.
But you have examined the patient lying down, so he's not putting any pressure on his foot.
Is it a persistent deformity that you cannot correct that? This oscillation will be if you have a persistent deformity, he cannot make it right angle. Then you describe this.
Okay, sir. Okay, sir.
Yes. What Dr. Huda, I will try to tell you why this is wrong. Number 1 is deformities are basically things that we will talk about. But dorsiflexion at the ankle is an extremely unlikely finding in a diabetic foot. You know why? Because of the diabetes affects the tendons, muscles as well. So there is problem in the tendoachilles in a diabetic foot, and that gets taut, contracted. So usually the foot is plantar flex rather than dorsiflex. Yes, so sir. This the moment you have written this, I know where to catch you. You know, this is where things are wrong. So this is you have to keep in mind. So you have written deformities, nil. Now this is the time, Mahunda, we will ask about deformities of the foot. Tell me the deformities that are likely in a diabetic foot. But before that, shall we just ask you a little question as to diabetic foot?
Yes, sir.
When does it start in a diabetic patient?
Sir,
when do you expect that?
Yeah.
After the onset of peripheral neuropathy.
Exactly. When does it start? That is exactly what I am asking. You have got the question right. It is usually 10 years from the onset of diabetes. You see, neuropathy usually starts. Why do patients have neuropathy? I know I am asking questions, but we have a short of time. We'll have to cover a very large topic. So why do patients have neuropathy in diabetes? Any ideas? So essentially, this is also we do not know exactly, but there are certain postulates. One of them would be that the vessels supplying the nerves, they are affected, and thereby there is neuropathy. Number 2, there is a problem regarding the myelin sheaths that can cause problems. Number 3 is there may be edema of the nerve trunks as well, so that can cause problems. So there are several theories as to how neuropathy happens. Which nerves are affected first, and thereafter how foot changes happen. The changes in this foot happen. You know, the deformities in the foot.
Nerves. You have somatic nerves, you have autonomic nerves. So which nerves are affected in sequence?
In sequence.
Sir, first somatic nerves, then autonomic nerves.
Yes. So what is the effect? Which the somatic has got sensory and motor
sensory
component.
component and motor component.
Which part get affected first?
Says first sensory part gets affected.
Yes.
After that, motor parts gets affected.
So what is the effect? What is the effect of this affection? Suppose autonomic nerves are affected. What happens to the food then?
So there will be muscle atrophy.
No, autonomic is not
No.
muscle. Autonomic is what?
Your third point
is
is that, the skin, hair, and nails that you have mentioned, this is autonomic nerve problems.
Yes, sir.
Okay.
Yes, sir.
The
Yes,
sweat glands. You see, the secretion in the skin get
Yes,
affected. Skin become dry.
Dry
Skin
and
become
shiny.
keratotic. Okay.
Yes, sir.
So,
Yes,
this skin ulceration, one of the important factor is this autonomic neuropathy. And then what happens if a sensory loss?
Yes, sir.
You see, if we look at the diabetic foot in general, the first thing that will happen is the sensory loss. Then there is motor problem. Sensory loss basically leads to trauma. So basically, there are minor traumas going on, and the patient tends to ignore them. And then comes motor. So motor nerve affection leads to the real deformities that start. It's a combination of the two. So what kind of foot deformities happen? And can you briefly tell me the mechanism of deformities that happen? What happens exactly?
So, in claw foot occurs in diabetic
Right.
foot. Yes,
you
sir.
are right. Let me just give you a little bit of help, so we'll get the subject. So basically, the intrinsic muscles of the foot, they are affected. So they get they lose the power. So
Yes,
they
sir.
are, so that is number one, atrophic intrinsic muscles. And so
Yes.
as soon as that happens, the extent the long leg muscles and their tendons, they take upper hand. So that leads to the classical claw foot. So basically claw toes. So essentially the metatarsophalangeal joints that they go downward. Okay.
Yes. Yes,
and,
sir.
and so basically, and then there is a development of claw foot, and there may be hammer toes as well. So this is unopposed action of the long tendons of the foot.
Yes,
working on the foot. The intrinsic muscles are gone. Then what
yes.
happens? There is abnormal weight distribution. And obviously, as I told you, there could be a bit of plantar flexion. So abnormal weight distribution that leads to certain, the arches may be affected. The arches may be affected in three ways.
Yes,
The
sir.
arch, so number one, the arch could be flattened. So you could have pes planus, that the medial arch is lost. That is possible. But more common is pes cavus, where the medial arch is exaggerated.
Yes, sir.
So that is more common. And the third one, where the patient develops neuropathic osteoarthrosis, Charcot's joint type, then they develop what is called a rocker bottom foot. So foot becomes convex. Instead of the arch is lost, foot may become convex. The central part of the foot is the most dependent part of the foot. That is exactly what happens later on. So you may have these three kinds of foot regarding arches. Now, besides this, the other problems could be, there could be excessive changes in the subtalar and the mid-tarsal joints. What can happen? These are very important to know, because this is part of what you have to examine. So if you don't know what to examine, you wouldn't know, want to see them. So this is what
movement occurs in the mid-tarsal joint? What movements occur in the mid-tarsal joints? The eversion and inversion.
Yes, sir.
Exactly. So exactly. And a diabetic foot, regarding deformities, must be examined not only in lying down position, but you must stand the patient up so that you can see the deformities yourself. Okay. So these both have to be done. Otherwise, deformities you cannot see. So regarding deformities, nil will not do. We will need to know whether he has got specific deformities, if any. Okay.
Yes, sir.
And then you will have to look at what sir was talking about, whether the patient has developed changes in the skin in relation to the deformities, that he has developed abnormal callosities, abnormal thickening, bunions,
Yeah.
whether he has developed all these. So changes in terms of callosity and skin changes secondary to the foot deformities, that has to be looked at. Okay, so
Yes, sir.
these things have to be seen. Now what you
Next
have
slide.
done here, next slide, exactly, this is not bad at all, this is good.
Yes, sir.
Next.
Palpation.
This is okay. Measurement of the ulcer is 8.5 into 7 centimeters, so it's a huge ulcer.
Yes, sir.
So basically it is always nice to have a picture, you know.
Yes, sir.
Yeah.
Yes, sir.
Yeah.
Nice to have a
And
picture.
again, you
The
have mentioned
classical
capillary
question.
filling and refilling. Behrul,
Yes, sir.
capillary filling and refilling are two different terms. What is capillary refilling and what is capillary filling?
Sir, capillary refilling is after pressing the nails,
Nail bed?
nail bed, and after removing we check the capillary refill time.
Yeah. And why do you mention capillary filling? That cannot be tested. Very difficult. Capillary filling time is different. This is demonstrated in patient who has got a peripheral arterial ischemia. You ask
Yes,
the
sir.
patient to lift the leg, the limb become pale. You ask the patient to sit,
Yes, sir.
the limb hanging. The limb become pale to pink and then become congested. So the time it requires from limb from pale to become pink is a capillary filling time, which is very difficult to appreciate in our patient population are very dark. So don't mention capillary filling. We just mention capillary refilling time. And I would expect that you
Yes, sir.
mention a separate point, assessment for peripheral ischemia. You have not made this point.
Exactly.
Because you have an ulceration. These ulceration can be infective ulcer. This
Yes,
can
sir.
be an ischemic ulcer. Okay, so your point should be, you have mentioned capillary refilling time, but there are some other points to assess ischemia in the limb. If you say assessment of peripheral ischemia, that will include what? You have mentioned these points in separate places, but all should come here.
Exactly. He is a
In
little
the,
disorganized. So
yeah, skin.
So
Skin
organize your findings in terms of, as I told you, ulcer, deformities, ischemia, and
Yeah.
neuropathy. So if you organize yourself in this way, then everything is covered.
Yeah. And
Yes.
you make a heading saying that you mentioned about nail, loss
Yes,
of
sir.
subcutaneous tissue, loss of hair, okay,
Yes, sir.
skin shiny or not.
Yes, sir.
Then you take this in one heading of assessment for peripheral ischemia. And then comes up peripheral pulses that you have described in details.
Exactly.
Secondly, examination for neuropathy. You say no peripheral nerve thickening. That happens in Hansen. But in diabetic patient, for
Yes, sir.
assessment neuropathy, you have to assess for sensory and motor neuropathy. So for that, you need to examine the patient and
Yes, sir.
make a heading like yesterday some boy presenting has done very well for assessment of the nerve functions. Okay,
Yes.
so you point at there, but points a little haphazard, and you have to make it a clear point so the examiner understand that you have addressed all these points. Okay, next slide.
Yes, sir.
Yeah. So you make a table, but what I'm trying to say is you see you
Yes.
have gone to the muscle bulk at the end. It's not
Yes.
there. When you're assessing a limb, patient has got peripheral ischemia, patient may have muscle wasting. So that comes much earlier when you are describing whether there is any gross wasting on assessment of inspection. And then if there is a objective assessment of wasting by measurement that you have measured. 33 means what? 33 centimeter?
Yes, 30 centimeter.
Okay. Length means what? You want to measure the limb shortening?
Yes, sir. Yes, sir. Yes, sir.
How do you measure the limb length? If I ask, is orthopedic question. Where from you start?
From the greater trochanter to the
Greater trochanter is much lower down. The hip joint corresponds to the level of anterosubiliac spine.
Yes, sir. Yes.
So you measure the leg from anterosubiliac spine up to the heel. That is the limb length.
Yes, sir.
Okay, patient may have some shortening because of contracture.
Yes, sir.
Okay, your points are there, but what I'm trying to say is you
Organize
arrange
that.
under proper headings.
Yes, sir.
Okay.
So it is quite nice to see that you have examined for pulses not only in the foot but all over the body. Why do you need to do that?
Sir, it might be due to atherosclerotic changes. If
What is the relationship of atherosclerotic changes to the disease in question, that is diabetes?
Sir,
so diabetes promotes accelerated atherosclerosis.
Yes.
Now,
Yes.
if you look at the pattern of involvement of blood vessels,
Yes,
could you tell me the peculiarities of affection in diabetes, atherosclerotic changes in the blood vessels?
So, first, peripheral arteries are affected first. After that, central arteries are affected.
We don't quite talk about, when we talk about vascular involvement, we don't quite talk about the way you are doing. So we tend to say the arteries below popliteals, infracrural arteries below popliteal are affected. Interestingly, foot vessels are not that badly affected. So usually the larger arteries in a diabetic foot are reasonably okay. The affection is mostly below knee, below popliteal. That segment is mostly affected. Okay. So we have to keep that in mind.
And in diabetic patient, you may not have large vessel getting involved, but there may be microangiopathy. Some patient in diabetes, you can find the pulses are palpable, but these are the patient who has got a non-healing ulcer. These can be a situation of microangiopathy. You see, diabetes can be a disease which is causing both macroangiopathy and microangiopathy. And this macroangiopathy may be atherosclerosis. So microangiopathy you cannot diagnose by palpating the pulses. This happens in the capillary bed because of the disturbance of the microcirculation.
Exactly. And because of the autonomic disturbances, lots of AV shunts are formed in the foot. So that is also another cause for ischemia, So not only macro and microangiopathy, but also because of autonomic problems, there is shunting of blood from the artery to the veins. So AV loss is there. Arteriovenous fistulas form and these channels open up. So that is another reason why there is a dearth of circulation there. Anyway, so it is nice to see that you have palpated. So what is the problem regarding palpation of blood vessels in a diabetic patient? See, the problem is you have mentioned edema. So yes, in the examination, there will be the problem. You see, you will talk about pulses palpable at the base of the ulcer. Ulcer is a big ulcer. You will talk about, say, for example, students make these grave errors. Like they're talking about a particular pulse which is on the territory of the ulcer. People tend to create this kind of problems in the examination. समझ में आया मैं क्या बोल रहा हूँ? Say you say you have palpated the dorsalis pedis pulse, for example, and the ulcer is over that area. So yes, you are immediately caught,
Yes, sir.
And if there is edema, palpation of pulses may be difficult. And as sir was mentioning, the pulses may feel normal. This is in response to the calcification of blood vessels and the affection mostly in the microvascular bed rather than major vessels as well. So that may also happen. So next, obviously, we will talk about neurology. So you have talked about the thing, monofilament test. Can you tell me what is a monofilament test? You seem to know a lot about it. You have mentioned all this. So let me ask you in detail. What is monofilament? So the first thing that we all have to understand, the endocrinologist will detect neuropathy.
Yes, sir.
That is the absolute standard, is to carry out tests using a 10G monofilament, 10G monofilament, 10 gram monofilament. So yes, how is this monofilament test carried out? At what points do you check the monofilament? How do you interpret a monofilament test? Let us go through this. This is, I think, objectively very, very important. Surgeons are usually not aware of this. Okay, carry on. You have done the test.
Sir, I have done the test using a monofilament that is present in my ward. So by
You have got a
that,
monofilament in the ward. So it is central government hospital, lots of money. Okay, fine. How do you do it?
no, sir, I was just using, sir, ethylene 10 ethylene.
No. Monofilament is a 10G monofilament. You cannot do this test casually. Monofilaments have to be absolutely specific. It is the 10G monofilament. So
This gives your fine sensation, 2-point
yes,
discrimination. You can apply
exactly.
2 monofilament and ask the patient whether he can appreciate that 2-point is being touched. So it
Yes.
is for fine sensation and also for 2-point discrimination.
Yeah. Basically, in the foot, there are 10 points.
Yes, sir.
So on the plantar aspect, there are 9 points. On the dorsal aspect, there is 1 point. The points are at the base of the first, third, and fifth toe, and then at the metatarsal head of first, third, and fifth toe. 1 point on the medial aspect of the plantar aspect of the foot, that is near about the arch. 1 on the lateral aspect and 1 on the heel. So these are the 9 points on the toe, on the plantar aspect, and 1 point in the dorsum, that is in the forefoot, close to the first web space. So these are the areas where you do the filament test. What you have to do is you have to press the filament to the concerned area up to and bend the filament to 1 centimeter and ask the patient whether they can feel. You have to have a pre-organized method of the patient says yes every time he feels that, and you have to obviously do so that he does not give you false results. You have to do this test, give a little gap between the 2 tests, 2 areas to be checked, check them at random. So essentially, we interpret if 3 times a patient fails to say that this is not, he cannot feel that, fails a particular point, that is considered as definitely this is not palpable. Okay, so definitely this area is insensitive. So
yes,
by monofilament test, we are trying to check for the protective reflexes, protective sensation of the foot. So if out of 10 points, the patient has 4-point loss, so that is gross neuropathy. You understand? So
yes,
single point loss will be interpreted as beginning of neuropathy. Beyond 4 points, the patient has gross neuropathy. So this is a fundamentally important test to do. And then you have done very good regarding reflexes. You have checked the ankle reflexes, knee reflexes, very good. So this is also you should do. The other thing that you can do is to checking for vibration sense. How do you check for vibration sense?
sir, using cuneiform, placing over the bony prominence.
What number?
250. 256.
Absolutely not. 256 is for audiologists. For neurologists, it is 128.
128. Sorry, sir, 128.
Not sorry, you have to know precisely.
Yes,
this is 128 for neurologists, and the other one for other business. So for neurology, it is 128 vibration. Okay, so neurological testing is mandatory, and this has to be done. Okay, so by N you mean he has got normal reflexes.
Yes, sir.
Okay, fine. And obviously you have mixed this up, neurovascular assessment. This will not do. You have to make separate neurological assessment and separate vascular assessment. Okay, next slide, please. And this is systemic examination you have done. Okay, and then you have given your diagnosis.
I'm supposed to make a summary. You have
yes,
not given us a summary.
Yes, sir. That during conversion of the slide, I think that has been deleted, sir.
Okay, carry on. You have made a good effort, but you need to be more organized. Nothing else. You have got the things, but it has to be organized properly. Okay, carry on. Give us a summary and your provisional diagnosis.
Sir,
it did not show the sites of management. It has discussed like exam scenario, because giving a presentation of management, it will be monotonous. We are trying to now go through the approach for this patient from your side. You say it's a diabetic foot ulcer. We're gonna grade 1B, and you also mentioned there is some associated edema in the local site, and you said patient has got fever.
Yes, sir.
You cannot ignore all this.
Yes, sir.
So what do you feel? Is just a non-healing chronic ulcer, or patient has got some other associated finding to be cleared?
Now, as in this patient, there was a history of only mild fever, and that was 15 days ago in this patient. So the
Patient has
fever,
got pain. Patient's got pain, swelling around the ulcer. What
yes,
does it
sir.
indicate?
Sir, it is an acute infective condition.
So it's a diabetic foot ulcer. It should be infection.
Yes, sir.
That should be at least there. You said 1B.
Yes, sir.
Okay, fine. So that is your diagnosis now.
Yes, sir.
And you say patient has got diabetes. If he's diabetes, from the diabetic patient, you should take one important history. What treatment he is on, and patient can tell you whether he is well controlled, or he will say that my sugar goes very high sometimes. So that means he is uncontrolled. That also should be ascertained on history of the patient. So
Yes,
he's
sir.
diabetic for a long time.
He's
What
diabetic.
treatment he's on?
Sir, he was on oral hypoglycemic agents.
How was the control? What he said?
Sir, poor
Did he
control. He was
monitor regularly?
no, sir. He did not monitor regularly, and he did not
So,
even take medications regularly.
no, then he's on irregular treatment. That is important.
Yes, sir.
Patient
Yes,
who
sir.
is on irregular treatment, patient is not monitoring his blood sugar, he
Yes,
might
sir.
be uncontrolled. You never know it.
Yes, sir.
Okay. So
Yes,
you
sir.
find obviously patient is saying my sugar has gone to 200 or 300. You have to say straight away that patient is uncontrolled diabetic.
Yes, sir.
So now then you have come up with this patient. So Dr. Somebody can discuss the management part of this.
Okay. So Dr. Huda, did you have more slides after this?
Yes, sir. For the management part.
The slides he has mentioned about the treatment.
Okay,
I'm saying that
okay.
let him answer.
Okay,
We ask
that's
him
fine.
question, let him answer.
Yeah. So
Yes.
basically, once you have reached the diagnosis, next
Yes, sir.
comes assessment of the patient. Now,
Yes.
assessment in the terms of laboratory and radiology and all that. That is
Yes,
what you have to do. So
yes,
a
sir.
patient has come to with this situation, diabetic foot ulcer, which may be infected. So
Yes.
how are you going to go about it? So what investigations will you order?
Sir, first of all, I will do some baseline investigation. As in this patient, he is having fever, so I will go for a CBC and FBS, PPBS to check for the sugar levels.
At least PPBS. At least PPBS. No. Try to understand. It's not a question of at least PPBS. Patient is diabetic.
No,
You have to do a comprehensive sugar assessment: fasting, postprandial blood sugar, HbA1c.
Yes, sir.
These three are mandatory. You just cannot say at least PPBS. This patient diabetes needs to be addressed. We want to know how was his blood sugar status for last 3 months, which will refer in the HbA1c. So don't say only at least. It's a complete fasting, postprandial blood sugar. And if you are going to manage the patient properly, you might need to do all the three, at least 4 blood sugar in a day.
Yes, sir. Yes, sir.
So, see, the questions can be asked in many ways. The questions can be investigations, and questions may also be how will you start management? With the diabetic foot ulcer in uncontrolled diabetic, the first thing got to mention, you're going to admit this patient. Whether admission is mandatory, I think this patient needs to be admitted. Uncontrolled diabetic with foot ulcer is in a high risk. With an 8-centimeter ulcer, he is likely to lose the limb. So you need to admit this patient. So first talk about admission.
Yes.
Next, investigation. Immediately what you have to do? Immediately you have to send some blood works. So blood will consist of a complete blood count, a fasting glucose, a postprandial plasma glucose. I think it is time that we stop talking about sugars and come on to glucose. Okay. So fasting plasma glucose, postprandial plasma glucose, glycated hemoglobin, HbA1c. So these three are mandatory. You will obviously maintain a 4-point CBG chart because you are going to put this patient on insulin. So he will need to be at least on a 4-point CBG chart.
Yes, sir.
And then you are going to check his renal functions.
Yes.
Then you are going to, so he needs urea, creatinine, and you may also need to calculate his glomerular filtration rate, which is mandatory because you will need radiology for him. Next, you are going to check.
CRP is also another investigation.
Next, a ESR and a CRP.
Yes.
An inflammatory marker because he has got ulcer, he has got infection, fever. So CRP and ESR are good. They are good because you can do objective assessment of whether your treatment is getting the patient somewhere. Improvement in these will suggest that there is some improvement. So ESR and SCRP are extremely useful. And so basically, you will need to do these immediately. Regarding the ulcer, what would you do regarding the ulcer? Investigation-wise.
Sir, I'll do an X-ray foot to check for the involvement of bone also.
No, talk about microbiology first.
Culture and swab culture sensitivity.
So superficial swabs are useless. You'll have to take a deep swab or a tissue biopsy for microbiology. Okay, the
Yes,
ulcer, superficial ulcer swabs are useless. So do that. Fine.
Yes.
That is that microbiology part. Next, you are going to do
mention that
radiology.
you will do both aerobic and anaerobic culture.
Yes,
exactly. And then you are going to do
anaerobic culture.
Radiology. You talked about X-rays of the foot.
Yes,
Okay.
Yes,
X-rays of the foot with the patient standing. Okay.
Yes, sir. Yes,
so that the deformities become more prominent. Now, the patient may not be able to stand. In such cases, obviously, it takes a time. So X-rays with load, without load have to be taken. Now, what changes in X-rays are you looking for?
What are the changes in osteomyelitis? Because X-ray may not be a very good, reliable investigation. There are maybe some pointers to a diagnosis of osteomyelitis on X-ray. What do you look at?
Sir, the cortex of the bone will be wider, and there may be
not wider. There will be cortical destruction.
Yes,
there may be periosteal reaction.
Periosteal reaction, cortical destruction. Okay. There may be pathological fractures. Okay. So all these things may be seen, but you are more interested in seeing gas shadows. You see, you need to see whether there is gas shadow in the soft tissue planes, whether there is a foreign body. So these are the things that you are actually looking for in an X-ray. And obviously, obvious skeletal deformities that are there. So X-rays have been done. Next, what would you do? So you have done blood tests, you have done microbiology, you have done an X-ray. So what else would you like to do?
Sir, I would like to do
it's a large non-ending ulcer. You have to keep in mind what are the important factors that will lead to your investigations. One factor is an infection.
Yes.
Second is ischemia.
Ischemia. So assessment of ischemia.
Neuropathy. Third is neuropathy.
Assessment of ischemia. So
how are you going to do assessment of ischemia?
So for that, we have to do a color Doppler scan of bilateral.
So shall we just stop even a minute? See, it is mandatory. We in this country, we do not have Doppler probes with the surgeons present. So in Western countries, it is present. So measurement of ABPI, measurement of ABPI is mandatory.
Yes, sir.
Is mandatory. Okay. ABPI is mandatory in all diabetic foot ulcers. ABPI have to be measured. Now, ABPI, how do you know how is it measured? Do you know how it is measured, ABPI?
Yes, sir. We have to measure in the forearm and after that in the just below the.
No. What equipments are needed? Number one, what equipments are needed?
You heard of duplex scanning? We discussed yesterday. You heard of duplex scanning? Duplex scanning combines a beam ultrasound and a Doppler probe. Okay.
Yes, sir. Yes, sir.
So for measurement of the ankle blood pressure, what you need? Can you measure the standard stethoscope?
No, actually, what sir is saying is correct. He is trying to lead you. You need a Doppler probe. Handheld Doppler probes are available. You have to use that to measure ABPI. So ABPI, so you have to check for ABPI. ABPI, the fallacies of ABPI in diabetics, any idea?
In diabetic
calcification of blood vessels.
Yes, sir. Sorry, sir.
In diabetic patient, is ABPI a good index? Sometimes ABPI may be higher than normal.
Exactly. Why? Exactly. If ABPI is more than 1, what should you suspect?
There is Most likely due to atherosclerotic changes, the ABPI is more.
Calcification of blood
Yes, sir.
vessels.
Yes, sir.
Calcification of blood vessels leading to incompressible blood vessels. So your cuff is unable to compress them well. So that is
Yes.
so in such situations. So ABPI has got its limitations, but it is a good investigation to start with. And then you can also do something called toe measurement of toe pressure. You can do toe pressure measurement. So if you do toe pressure measurement, that
So
is
you have fine sheath, fine cuff. We apply around the toes and listen with the Doppler probe on the digital vessel.
yes.
You can measure the toe pressure. Toe pressure is said to be more sensitive in diabetic patient.
Absolutely.
So toe pressure index is important.
So your patient has got a toe pressure of 20 millimeter mercury. What does it mean? Your patient here, Mr. Huda, Dr. Huda.
Yes, sir.
That means his ulcer is unlikely to heal. You see,
toe pressure 20
if
means
toe pressure
gross
is
ischemia.
below 30 is unlikely to heal. So these patients need vascular reconstructions, otherwise this will not heal. You get my point? So
Yes,
this
sir.
is why it is important. So any other vascular workup besides doing Doppler and other things, lab-based tests. So you can ABPI is one, measurement of toe pressure is one, and the third one, which I would like you to know, is transcutaneous oxygen pressure.
Yes, sir.
So that is a very, very good test. TCO2, transcutaneous oxygen pressure. It is probes are available by which, again, if that shows low values, then that patient needs vascular reconstruction. Otherwise, these ulcers will not heal. So this is lab-based test. Now you will come to Doppler, as sir was saying. Do a ultrasound related test. So do a duplex study of the arterial system with a measurement with the Doppler study, which we have to see the flow. So we can do that test. So that is basically, we have already talked about the areas of problem. So this is intracural, so below popliteal, and this area is usually affected. So that is a very, very important test to do. Now
we discussed yesterday about the various findings in duplex study, which will suggest that patient has got a peripheral arterial occlusive disease.
Yes, sir. So what are the things? Classes are back-to-back classes. Yes.
Yeah. So first thing is in duplex study, you can measure the flow velocity.
Yes, sir. Peak flow.
Okay.
Peak
flow velocity.
Yes, sir.
Number two, you can have a pulse wave tracing. A normal pulse tracing will be triphasic. Patient who has got narrowing of the vessel may have biphasic or monophasic pattern of pulse wave tracing. Okay. You can measure the segmental blood pressure. You can measure the blood pressure in the thigh, in the calf, in the ankle. So if you find there is more than 20 degree deviation of the segmental blood pressure, that indicates there is stenosis at that particular segment. Okay. And then you may have audible signals on duplex study. In normal artery, you hear lap tube sound. In a stenosed artery, you can hear the murmurs or rumbling sound. So these are all things you can have from a duplex study. You should keep in mind, you say duplex study, but what you get in duplex study, you have to mention all these important points, which can give an idea about the level of stenosis.
Yes.
Now you plan, as I said, patient might need some vascular intervention. So in that case, what do you do? If you're planning for a vascular intervention, only duplex is not the investigation you go for vascular intervention. What you need next?
So we have to do angiography of the CT angiography of the arterial system.
What is the limitation about CT and MR angiography in patients of diabetes? For example, let's talk about CT first, then we'll talk about MR. So which is better, a CT angio or an MR angio?
Keep in mind that diabetic patient may have associated renal dysfunction. If the patient has got renal dysfunction with urea creatinine being high, you cannot use the hydrogenated contrast. So CT angio is not
has hit the nail on the head.
Okay.
Absolutely.
But MR angio, you can go ahead.
Yes, sir.
Sir, MR angio gadolinium also can cause nephrological problem. It also causes a very peculiar subcutaneous fibrosis. So gadolinium also is not without trouble. So, but in a diabetic, an MR angio is probably better than a CT, because you get an MR scan and an MR angio. So that is, see, as we forgot that point to ask. So after doing X-ray foot regarding osteomyelitis, the best test would be to do a
MRI.
MRI of the foot.
MRI, sir.
Yeah.
MRI of the foot. So that is what we needed to ask you. So we forgot that point. So we went back one step. So X-ray, MR of the foot, MRI of the foot, and then an MR angio would be the ideal answers to these questions. Okay. So
Yes,
MR angio. Now question is, what is your idea about vascular reconstruction in diabetics, with the diabetic foot? Where is the problem? Do you understand what is an inflow, what is an outflow?
So, because in the grafting the patients, the in which artery will anastomose, mostly the arteries are not good to anastomose at that place.
No. Answer this simple question. Regarding vascular reconstruction, whenever there is a vascular reconstruction involved, we talk about inflow and outflow. What do you mean by inflow? What do you mean by an outflow?
You have a level of obstruction.
Yes.
So to do a bypass graft, what you need proximally and what you need distally?
In proximally, we need also good flow, and
yes,
exactly.
And distally
also good flow.
Need good network for the blood to go. Otherwise, if there is obstruction distally as well, there is no distal runoff. That is, outflow is poor. The reconstruction will definitely fail. The graft will fail. It will undergo thrombosis. So you need to have good inflow as well as outflow before physical reconstructions. Now, as you have already, so this is inflow outflow business. So now tell me, what kind of reconstructions can be contemplated in a diabetic foot ulcer regard to improve ischemia?
How do you decide about endovascular versus open bypass?
Yeah.
So we can do femoroarterial bypass surgery.
Then how do you decide? Because
how do you decide? When do you
surgery in the elderly diabetic patient is again a complicated situation. Now there are good number of endovascular procedures, but there are some limitations also for that. If you find a short segment stenosis,
yes, sir.
So that can be addressed by endovascular.
Yes, sir. Endovascular stenting process.
Now come to the ulcer. How do you manage this ulcer? You say you mentioned 8 centimeter by 7 ulcer is a big ulcer. So what is the strategy for ulcer management? You have some slides, you are mentioning some points. Come to those.
We are almost running out of time. We will go about it quickly. No problem.
Yes. How to manage the ulcer?
I think we have covered everything more or less.
Yeah. Infection, first is diabetes control. If there is systemic sepsis, take care of the patient as a whole.
Exactly.
And third is a empirical antibiotic followed by a proper antibiotic based on culture sensitivity. Okay. Now come
local
the
debridements.
This is large ulcer.
So we have to debride the dead tissues.
You said there are a lot of red granulation tissue.
Yes, sir.
And if you have a ulcer with dead and devitalized tissue, you need to do debridement. Yes.
Debridement.
Yes, sir.
Okay. Followed by, if you have a such a large ulcer, do you think this ulcer will just keep on healing by dressings?
No, sir. We can apply vacuum assisted closure devices.
Good.
What
negative
device?
Pressure devices.
Yes.
Negative pressure devices.
Yes, sir.
And you should first, before you apply negative pressure, you have mentioned one point, offloading.
Offloading.
Sir,
you mentioned one point, offloading. Why offloading is required?
Sir, because after applying dressing, and that point is repeatedly pressure is given on that point, means that point will not heal. We have to change the.
So you have to avoid pressure on the wound site.
Yes, sir.
So that you can achieve by offloading.
Yes, sir.
Offloading के technique क्या है? What can you do for offloading? How do you offload?
There is specialized shoes and orthopedic
So
Appliances.
some special shoes will work, and then you can offload the entire leg. There is no weight bearing, so you can do a total contact cast. You have special orthopedic appliances by which the weight is not put on the foot at all. Okay,
Yes,
so
sir.
you can do that as well. So
Yes,
that can be a wheelchair as well. There can be admission and wheelchair as well. So offload completely. Number two, take care of the ulcer, debride.
yes,
And
sir.
amputation, I think we are running out of time. Amputation we can't discuss today. So,
So one is negative wound pressure therapy, and following that, if you have a large raw ulcer area, how
So
can
what
you
do you
achieve
do?
coverage?
Later we have to do skin grafting.
What do you mean?
Skin
Split graft?
grafting may work on the dorsum of the foot, but plantar aspect,
Yes.
simple skin grafting is not
Yes. Will not work.
useful.
So you have to think of some flap coverage.
Flap coverage.
Yes.
The dorsum of the foot was skin grafting may do, but under surface plantar aspect you have to do flaps.
Yes.
Okay, and then vascular improvement you have done, and then that should take care of it. What can you do about neuropathy? Can you do anything to improve neuropathy?
So these are irreversible changes.
Exactly, you can do nothing much. You can do nothing much. You can only control the sugar and hope for the best.
Yes, sir.
Okay.
The last point is in diabetic patient, there is another point now being mentioned, described as immunopathy, to explain this infection and ulceration. What immunopathy happens in diabetic patient? You see, vasculopathy,
Yes, sir.
neuropathy, infection, and immunopathy. What happens in diabetic patient?
Cellular immunity as a whole is depressed, you know.
Yes. So the phagocytic activity of the WBC is impaired.
Absolutely.
Okay.
Immunosuppression.
Once the WBC is impaired, this W has got local function in the form of releasing some cytotoxins, and this release can cause local effect. Okay.
Yes.
So
Yes,
this immunopathy can impair the local fighting against the invasive organisms. Okay, that is one important factor for diabetic patient. Okay, so we've gone beyond time. There is no question in the chat box, so we can conclude. Okay, Barul, you have presented well, but what I'm trying to say is you just arrange your findings and give more emphasis on the history part. You take more of the history to say whether the patient has got disease, cardiac disease, patient has got abdominal symptoms, patient has, because in the history of present illness, that has to come. You are excluding the other systemic disease. We are not confining only to the ulcer, because the ulcer is there, yes, but you are doing a comprehensive assessment of the whole patient. So that is important. Okay.
Yes, sir. Yes, sir.
And the only thing that we have not, thank you, sir. We have not touched amputations. So please take some time to learn amputations. This is important in diabetes. Okay.
Yes.
When do you consider amputation in the emergency basis? One question. When there is patient require amputation on emergency basis, you have to do urgent amputation. Otherwise,
and what kind of amputation should that be? What type should that be?
When you need to take amputation as a life-saving measure.
So if there is a vascular injury has occurred or
not vascular injury.
No, in a diabetic.
Diabetic patient, not vascular injury.
So
if you have a spreading infection, have a spreading infection with gas-forming organism.
Exactly, sir. Necrotizing fasciitis. Patient develops necrotizing fasciitis.
Yes, so that patient may die. So in that case, you need to do a guillotine amputation. You just chop the limb off. You don't try to close the wound.
Close it.
You do a guillotine amputation. So this is a situation where you need to do amputation emergency basis. Patient has got a spreading infection, particularly the gas-forming organism. Patient is systemically unwell, and patient is having features of systemic sepsis.
So such situations.
In that case, you take this site of infection off. Do a guillotine amputation on emergency basis.
Yes, sir.
Okay. Thank you. Thank you very much.
Thank you, sir.
Thank you.